Hello, everyone, and welcome. Welcome to this webinar, which is organized by MFNet on life course immunization, a safer world for all ages. My name is Linda Wood. I'm a technical officer working with MFNet, and I'm happy to be your moderator for today's discussion. Our webinar will be focusing on life course immunization, a fundamental component of public health. As we know, immunization has made remarkable strides in preventing infectious diseases and protecting the lives of children. However, as we look ahead, changing demographics and evolving disease patterns and new vaccine developments present both opportunities and challenges. Aging population bring concerns of declining immunity, while emerging diseases necessitate tailored vaccination approaches, not only targeted to children. The immunization agenda will set the background for our discussion. The immunization agenda aligns with immunization with the Sustainable Development Goals and seeks to ensure equitable vaccine access for individuals of all ages. The concept of life course immunization is a strategic response, not just for older age groups, but for individuals of all ages. It encompasses comprehensive vaccination throughout the life through optimizing resources and promoting collaboration across healthcare programs. This approach emphasizes vaccines for all age groups. Today, our webinar will be focusing on strategies for strengthening immunization policies and service delivery. We will explore improving vaccine coverage, integrating vaccines with healthcare services, addressing vaccine hesitancy, and reaching vulnerable populations. We will listen to three distinguished speakers: Dr. Osama Mir'i from WHO, IMRO, the Regional Office of the Eastern Mediterranean, Dr. Suhal Bayat from the Qatar Ministry of Health, and Dr. Kira Sugarman from the CDC. I encourage all of you to use the Q&A box to add your questions, and we will give time at the end of the panel to answer your questions. So without further ado, let me give the floor to our first speaker, Dr. Osama Mir'i, who will provide insights into the strategies for strengthening life course immunization policies and service delivery. Dr. Osama Mir'i is the life course immunization lead and COVID-19 vaccination regional coordinator at IMRO. He's a public health specialist with over 27 years of experience at the national and international levels. He also has extensive training in health system management and served as the National EPI program and head of the Child Health Unit at the Ministry of Health in Syria. He moved to work with the WHO in the field of immunization, vaccine introduction, polio eradication, and measles elimination, as well as in disease surveillance and emergency. He has a variety of experience in different countries, including Sudan, Yemen, Egypt, Jordan, and Pakistan. So please join me in extending our warm welcome to Dr. Osama. Dr. Osama, the floor is yours.
Oh, thank you very much, Ms. Lin. And let me start with sharing my screen first, and then to say that I'm very happy that to be here in this webinar. I hope you can see my screen.
Okay. Yes, we can see your screen.
Okay, let me minimize this. Okay, thank you very much. And let me start with thanking you, Ms. Lin, and thanking MFNet and GHD for organizing this very important webinar on very important topic. And I will try to talk about the life course immunization, what's the strategies to strengthen the immunization policies and service delivery. And as to set the stage for the discussion or for further elaboration, I'd like to say that we have the IA 2030. Now everyone knows about it, which is our unifying vision for the decade, aligned with the SDGs with the clear impact goals. Our vision in this IA 2030 for this decade, a world where everyone, everywhere, at every age, fully benefited from the vaccines for good health and well-being. And one of the impact goals is to reduce the mortality and morbidity from the vaccine preventable diseases across the life course. We are not talking here about only children. And this is the main change in this IA 2030. And one of the impact goals, again, to leave no one behind by increasing the equitable access and use for new and existing vaccines. And of course, we need to ensure good health and well-being of everyone by strengthening the immunization within the primary care system and contributing to universal health coverage and sustainable development. So in this IA 2030, we have 7 strategic priorities and 4 core principles. The 4 core principles, let me say it first, it is to be people-centered and to be owned by the countries, to be the partnership-based, and then it is guided by the data. And the 7 strategic priorities, I'll not mention all of them, but at least the first one is the immunization programs for primary health care for better universal health coverage. This is the first and the most important, like, strategic priority, but we have the 4th strategic priority, which is the life course and integration, which we are talking about in this webinar, which is the 4th strategic priority. And here the main goal for this, the life course and integration, that all the people to benefit from the recommended available immunization throughout the life course, effectively integrated with other essential health services. And we have 2 main objectives, is to strengthen the immunization policies and service delivery, what we are talking about in this webinar, through the life course, including appropriate catch-up vaccinations and booster doses. You will see that we are talking much nowadays about the catch-up vaccination, especially about after the backsliding, during the backsliding in the immunization system and in the immunization coverage during the pandemic. And of course, we need to establish integrated delivery points of contact between the immunization and other public health intervention for different target age groups. What we will benefit from the life course approach to vaccination. In fact, our main goal is to reduce the mortality and morbidity from the VBDs for all people at all ages. And in this case, we want to use all the opportunity to give the new vaccine or underutilized vaccine. I can give an example of HPV or many other vaccines. Booster doses, since we have the life course, we assume that we have now the platform for the life course. We have to even to give the booster doses, which many of our country in our region, they don't give the booster dose, like for DTP, for measles. So we can working on this, especially that some of these vaccines, like diphtheria, it's exposed to waning immunity, and then we can do the catch-up vaccination for missed children. Now, most of our like EPI, they are talking about under 1 or maybe under 2. But we need to target the children under 5, especially after this pandemic, when we have now all the cohort under 5, they have good proportion of them, they are not protected. They got 1 dose or they did not get any dose. That means they are not protected. And the life course immunization is giving us an opportunity to integrate with other health services. And then we'll see what's the benefit of the integration. And of course, we are reducing the burden of on the health system, which is very important. If you remember during the pandemic, how it happens that we're very much like strained. The health system, they were very much strained because of the health workers drainage. And then we can improve the country preparedness. During the pandemic, we were not prepared. We were not having like a platform to vaccinate the adults. But by doing this now, the life course approach, I think we will be very ready to establish platform, to give the vaccine for all age groups. And then by this, we'll have like a policy for the catch-up vaccination. What the benefit of the integration? It's very easy to increase the coverage of any other health services we are integrating with immunization to the same level of the coverage of immunization. And as you know, the immunization coverage is the highest coverage and most structured, well-structured even programs among the PHC programs. And of course, we need to improve the system efficiency. That means that we have scarcity of the resources, we can use it efficiently, and to reduce the redundancy and the cost of, because when you add with the same cost or with additional marginalized cost, like 2 or 3 health services, that means you are doing it in very efficient way. And then whenever you are offering more than one services, multiple health services, then you are improving the user satisfaction, the convenience, and then able to meet the multiple needs for the patients. And the most important thing that you will increase the demand, because some of the people, you remember, if we talk about only the polio campaign, the people who are giving us only the drops while we are in need for more services. And of course, they have the right to say this. Because of that integration of health services, it will be very important either in the health facility or in the outreach activities. Here, this diagram will show you the life course. And as you can see, we divided here the age to these categories or these stages, starting from the pregnant to the older person. That we have pregnant woman, newborn, infant, second-year life, child, adolescent, adult, and older person. Of course, what you see above the line here, it is the vaccine which is given routinely in EBI. But under this, it can be given according to the epidemiological situation and according to the need. But what I want to mention here for the pregnant as a special group, if you want to say, it is we need to give the tetanus vaccine, tetanus toxoid containing vaccine, and seasonal influenza. As you can see, the seasonal influenza is across all the ages, but of course we have the highest risk group we need to focus on it, which is like pregnant, the older people, adult, and of course the comorbidity. And this the same is applied to the COVID vaccination, which is now we are very much focusing on vaccinating the priority group. We are not going for the overall or for the overall universally vaccinating the COVID-19 vaccination. And the good thing that now we have the malaria vaccine, and I think by the end of this year we'll have pre-qualified vaccine, and it is approved even to be supported by Gavi. This is the good thing. Another vaccine or component we can say, we talk about the hexavalent vaccine is approved now. Another window to be supported. I'm sorry, this is the hexavalent. I'm talking about at the end of this year to be pre-qualified. There is one, the Indian one, to be pre-qualified at the end of next year. The malaria vaccine already pre-qualified, but of course the manufacturing is we have like some shortage in the global market because it's a new vaccine. As you can see, this is in general. For integration across all these ages, we have all the other like programs we can have an opportunity to like the tetanus with the reproductive and maternal health services, and the neglected tropical disease, malaria, hearing screening, HIV, nutrition, water, wash, health education. All these programs, once we integrate with them, I think we'll get better, more efficient, more effective health services. Now, let me talk quickly about the health workers, because as you remember, even the life course immunization, including the health workers, and we need to preserve our health systems, especially during the pandemic. So because of that, they need to be vaccinated. I'm just here to mention that we have as WHO, we have the global guideline for the workers, health workers vaccination. And I hope that you can go through it. I'm not going to take time on this, but just to let you know that to be in your resources. And then we have the catch-up. If you remember, we said the catch-up vaccination is one of the most important component of the life course immunization. And the catch-up vaccination, it needs always to have the policy, and you need to have the catch-up schedule. And I hope the other speakers, they will talk about this, especially Dr. Soha will give us like an example from the countries, especially from Qatar. And of course, the catch-up vaccination, if we talk about under 5, we are not talking about now, because you remember this initiative, it was launched with the World Immunization Week in April 2023 this year, but we meant to make it like on sustainable basis, on continuous basis. Once it's introduced, any child comes to you, we need to check about and to screen about the vaccination history, and then to give the missed doses. All the time, when the country, they don't have policy for the catch-up vaccination, if they don't have even guideline and very well written, simple guideline that to increase the knowledge of the health workers, and if you have very strict upper age cutoff for catch-up vaccines, so if the child 5 years and 2 months, 5 years and a half, 6 years, what there's no problem. You don't need to be very much strict. All of these, if you don't have the policy, you don't have the awareness of the health workers, and if you have very strict upper age, you are missing many of your opportunity to vaccinate more persons, I can say here, which lead to inequity in our distribution and delivery of the vaccine. Catch-up vaccination policy, what should it include? In fact, it is very important to include the vaccination to identify those who have missed one or more doses within the national immunization schedule. And then how to determine the eligibility. That's what we are talking about here, about the guideline, to be very simple guideline for the health workers. If a child came to you with the 3 years and got this dose and this dose and this dose, what's missing, what you need. So you need to know the age ranges and the history of the vaccination, and if not, you don't have document what to do, well, how to behave, and of course, we need to know at the interval between the doses, and then we need to train them on how to record and report the delayed doses for children above 1 or above 2, and leveraging every health contact as an opportunity to check vaccination history and catch up on vaccination, as we mentioned previously. A catch-up schedule, which is it's mandatory, it's imperative to have it in every country whenever you are doing this catch-up. We said that you need to have policy, you need to have the national schedule for the delayed or interrupted vaccination. Then you need to have in this the age cohort or to which the catch-up schedule applies, like under 5 instead of under 2. Instead of saying under 2, we need to vaccinate all children under 5. The minimum age, maximum age, and upper age limit as per your national policy. Then a clear directive on immunization, minimum interval, as I was just mentioning, between the doses. Because sometimes in under 1 or under 2, the minimal interval is 1 month. It is the older children, it can go for 6 months in some of the vaccines. Finally, I just want to refer you to the table 3, which is famous table 3. We have in WHO, we have table 1, table 2, table 3. Table 1 and 2 talking about the routine immunization schedules, the recommended one for WHO, and table 3 is recommendation for interrupted and delayed routine immunization. Of course, you don't need to read it. I don't need to tell you what is there, but just want to say it is almost always better to vaccinate later or late than never. And by this, I stop here and over to you, Nassim.
Thank you so much, Dr. Osama, for this very informative presentation. Definitely, we enjoyed listening to this presentation, and you have shed the light on the immunization agenda, and also you introduced the concept and the benefits of life course immunization, and also the benefits of integration, which we will learn more about in Kira's presentation later on. And I encourage everyone to go through the resources that Dr. Osama has mentioned, including the implementation guide for vaccination for health workers, as well as for the recommendations and guidelines for catch-up vaccination. And also thank you, Dr. Osama, for highlighting and emphasizing on the importance of having catch-up vaccination policies and schedules. So thank you so much, Dr. Osama. And let's now move on to the second presentation, which will be presented by Dr. Suha Al-Bayat from the Qatar Ministry of Health. Dr. Suha was the head of vaccination at the Ministry of Public Health in Qatar, but she was also recently promoted to the Director of Health Emergency. Dr. Suha, to her, public health and vaccination is not just a job, but a passion that she is a strong advocate for vaccination. She is a community medicine consultant, but also holds several other degrees. She is trained in aviation medicine, occupational medicine, and she holds a master's degree in healthcare management from the Royal College of Surgeons in Ireland, and also a diploma in travel medicine from the Royal College of Physicians and Surgeons in Glasgow. And she's also a fellow in the same college. She holds the Arab Board of Community Medicine, and during the COVID-19 pandemic, she was appointed as the national lead to the track and trace team. Dr. Suha, welcome, and the floor is yours.
Assalamu alaikum and good afternoon or good morning, depending, or maybe even good evening, depending on where you are across the world. Thank you, first of all, to Infinite for inviting me to be part of the speakers in this important topic today. And if you'll just give me a second to share my slides. Just give me a second. For some reason now it's not working. No, I think I shared the wrong.
Okay, Dr. Suha, let us know if you need support. We can share from our side. If
it was working beautifully just a minute ago, and unfortunately, as I said, I made some modifications to my presentation, but that's okay. It's for some reason it's not showing. So if you can please just go ahead and maybe share from your side.
Yes.
Okay, thank you so much. This is going to be like a very brief presentation on maybe not just the success, maybe it's just how we deal with things in the state of Qatar when it comes to vaccination. Next slide, please. Okay, this is just a very quick slide just to tell you about Qatar. Qatar is a Middle Eastern country. It's part of the Gulf Council in the GCC countries. As you can see, the entire country is just short of 12,000 square kilometers. Our population is dynamic. So we have an average of 2.8 million, the majority of which are expats or residents, not nationals. And we have very good, I would say very good, not just good access to healthcare, because we have pre-HCC, which is the primary healthcare clinics. We have Hamad Corporation, which includes all the hospitals, the government hospitals in Qatar. We have semi-governmental, and of course, we have the private sector. Next, please. Okay, now the biggest immunization barriers, here it says access, but what I meant to say was also confidence and trust in the vaccines. So it could be either lack of access to the immunization and or, next please, vaccination services are simply not convenient. So saying that, next please. What we need globally, and here I'm not talking about Qatar, here I'm talking globally speaking, we need tailored strategies to enhance the vaccine confidence among the community and the uptake, or let's say access. Next. Okay, so we have different barriers to vaccine confidence and uptake. We have structural barriers, next, behavioral barriers, and informational barriers. Next. So when we talk about structural barriers, for example, what we're talking about, it could be the physical access, it could be a policy, it could be the cost. When we talk about behavioral barriers, it could be the culture, it could be, if you can just press next, thank you, and next, so it makes it easier. So we could be talking about that people simply forget, it could be mistrust, it could be uncertainty, it could be so many different things that is the behavior of the person and how they deal with vaccination. Next. Or it could be simply informational barriers. Especially now after COVID, we saw how much mis and disinformation is circulating, how vaccine hesitancy was more of something that we didn't really see in our part of the world. And suddenly, ever since COVID started and the COVID vaccines, we saw an increase in this hesitancy because the world has become very small with social media, and it allowed such mis and disinformation to circulate. Next. Now in Qatar, We have a life course immunization program. So if you just click next, please. We have childhood, adolescent, adult, pregnant women, elderly vaccines. We also have for the special groups, and we say special because we sometimes, you all know, we target specific groups. So healthcare workers, chronic diseases, the immunocompromised, high-risk groups, and of course, travelers and travel clinics and immunization. And then we have the special situations where either somebody was exposed to a certain disease, for example, let's say chickenpox. So if it was like in a closed camp and they are not sure if they were vaccinated before, we can go and give them the vaccine for those who were exposed. Or if there, God forbid, was an outbreak, then we can do an outreach and like a campaign either to a specific community, part of the country, or the entire country, depending on the situation. Next. Okay, now, who is targeted by the vaccine? As you can see, everybody. And where is it delivered? If you can just press next. Okay, yes. Okay, so if you see on the left-hand side of the screen, when it comes to childhood, there are two columns. The first column is talking about the mandatory vaccines, which comprise our national immunization program. And the shorter list is optional. And it's, even though we advocate for influenza, but it's an optional vaccine. Meningococcal and hepatitis A, it depends on the high risk and if they are traveling to high risk areas. Even though you don't see influenza stated in adolescents, adult, and maybe in other air or travelers, but it is there, it is included. But we have, for example, for adolescents, we have the Tdap, the recently introduced HPV and MMR, depending on if it's time to do a catch-up campaign. And Tdap, we usually target grade 10, girls and boys at school. Adults, we have, again, the HPV vaccine, which was recently introduced, because for us, even though our main target is the young adults and the adolescents, but it's been approved from 9 years old to 45 years old. And those older groups, it depends on the risk assessment by the physician. Of course, our elderly community, we have the influenza, PCV, herpes zoster, and we're talking about RSV, and we're going to see where that goes. Pregnant women, we have the influenza, the Tdap. The travelers, this is not the full list of vaccines. It will depend on where they're traveling, the activity they're planning, which part of the country they're going to. So there's so much that's given. And if you press one more time, please. And of course, COVID-19. I put COVID-19 vaccine separately because it actually includes all these categories. And one more time. Okay, so we spoke about the types of vaccines targeting the various groups. But now, where is it delivered? To make sure it's accessible, we have a variety of locations. So health facilities, it could be governmental, semi-government, or private sector. When we say schools, for something like the Tdap, where we go to the schools and we vaccinate the children in the schools. When we say home care, we took into consideration elderly people or bedridden people or people with circumstances that doesn't allow them to go to the health facility. We have what we call home care service, and it includes the vaccination. Even during COVID-19, where we had people who found it very difficult to move their elderly to the facilities, we went to them and vaccinated them at home. Workplace, again, to take away the excuse of no time I'm at work. When we do some campaigns, we go to their workplace and we provide the vaccine. Plus some companies, major companies like the airline, the airport services, the public transportation, they have their own setup and clinics, and they are licensed to give the vaccines for their own staff. And of course, then there is the campaign, another way of delivering vaccines. Next. We wanted to make sure that vaccination is having equitable access and that we build trust in the state of Qatar. So what we start with is the leadership and legal frame. We have a very, very strong political commitment. It's in the law when it comes to vaccination, especially when it comes to the childhood vaccination. We have policies, we have regulations, and these policies and regulations depend on the type of vaccine we're talking about. So it's either a mandate like the National Immunization program. It's a nudge where it's not really compulsory or mandatory, but you're kind of pushed towards taking the vaccine, or it's simply recommended. When it comes to planning, coordination, and management, we have NITAG, which is the National Immunization Technical Advisory Group, where all vaccines have to go through them to be approved to be introduced in the country, to change the schedule, to set the schedule, to update it. It has to go through NITAG. And we have various range of vaccine delivery options, as I mentioned before, public, semi-governmental, or private sector. Next. We have a very strong supply chain management. We have regulations, we have laws to make sure any facility that delivers the vaccine have to meet the requirements of the Ministry of Public Health, and a very strong, effective vaccine management. We also do in the Ministry of Health a monitoring and vaccine safety protocols. So what we do is we monitor the uptake, we monitor any side effects. And what we did over the past, and actually coincidentally with COVID, is introduced an automated software. It's called SAVES, which is an acronym for the 2 points here, which is a vaccination database and a vaccine preventable diseases surveillance, and not just vaccine preventable, a surveillance for any communicable diseases. So the minute a physician gives a vaccine to anybody in the state of Qatar, it will come into this system, and staff or designated people in the ministry will be able to know. If there is a report by a suspected or confirmed communicable disease in the country, it will go through the same system. And again, designated people will immediately pick it up, start the investigation, so we can start any intervention measures needed immediately to decrease any or decrease the chances of any outbreak. We strongly monitor any adverse events, and we monitor the population's response and perception to these vaccines. So we monitor even social media, we see mass media, whatever it is, we monitor the people's opinions about these vaccines. Next. Okay, thank you. So vaccine delivery, we make sure that it is physically accessible to all. That's why we have more than 30 public health centers, and they are physically and literally located in every location in the state of Qatar, from the extreme north to the south and anywhere in between. We made sure that these sites are convenient. We made sure that we have vaccination campaigns, and we have a variety, either school-based, home-based, or workplace. We made sure our program is patient-centered. We have appointments for the vaccination. We have recommendations given to the providers so they can advocate. And so we avoid missed opportunities. So even if they're there for something else, they'll be asked and recommended of vaccines. And of course, we have a system to remind and recall if somebody missed their vaccination. Resources, we have human resources management, trained staff, and all of this is run by the Ministry of Health. And to ensure that all the rules are followed properly, there are vaccination guidelines distributed and updated regularly. Communication. We combat misinformation. We make sure that we are transparent with the population. We provide them with all the information needed. We also provide the healthcare workers with all the information and data they need to respond if the patient simply comes and asks them. And we even have like a social network of people and advocates to assist us to communicate with the community. Next, please. I'm going to share with you about 4 stories, and that would be the end of my presentation once I share these stories of success stories. So first of all, the success of our routine vaccination program and the immunization program. One of the things that helped is the fact that it's a mandatory schedule. Number 2, it's free of charge, regardless if you are a Qatari or an expat, if you are a resident or a citizen, it's free of charge. We made it accessible, again, to all categories. Regardless, we made sure that you have easy access to the vaccine. And we gave variety of options to people. Over time, we changed our vaccines to a multi-antigen vaccine, so hexa, penta, etc. So that made it less traumatic to the child, and therefore the parents when they're giving their children the vaccine, and made it a lot faster and easier. We have a formal WEBi clinic, and to ensure, again, accessibility, it's in the morning and in the evening and even on weekends. So people don't have the excuse of not taking their child to the WEBi clinic. We have appointment, reminder, and recall base. You'll see the word communication repeatedly said, because we work very closely with our media and communication team to ensure clear, correct messaging is going out. And of course, what we did is we made it a school entry requirement, which is like a checkpoint to make sure children have taken their vaccine. Just to show, if you see that graph on the upper right-hand corner, you'll notice, if you see the gray color, which is year 2020, which is at the peak and the start of COVID-19, there was a slight drop in the vaccine uptake, but we never went below 80%. And that wasn't because of mistrust. It was just the fear of going out, the fear of going to clinics, possibly crowded, and then maybe catching COVID. But that only lasted for a few months. And immediately, with reassurance, the trust of going out and going to the health centers picked up, and people started going back. And you'll see the difference immediately in 2021 and 2022 with the yellowish bar and the blue one, where it went right up almost to 100%. And even though in Qatar we didn't have a lockdown, but most employees were working from home, so we still made sure that they are able to take their children to take the vaccines, and we made sure that all precautions and infection protection control measures are in place. If they were quarantined or isolated, we made sure we rescheduled them, and again, effective communication. Next story. Next. Oh, COVID vaccine, thank you. No, if you go back, yes, thank you. So the COVID vaccine, I'll just go very quickly, maybe not through word by word for this, but start with looking at the graph that's there. Qatar is in burgundy color. And if you'll notice that when it came to the vaccine doses per 100, we started low and then it continued going up and then stabilized. Same thing with people who at least took one dose. Same thing who completed all doses. It kept going upwards and then stabilized. We did not have a drop per se until we finished the primary series. Then the third and fourth boosters, there we saw a decrease. We had very high political commitment. We started the procurement of the vaccines very early on. That's why we were one of the first countries to start the vaccination. And even though I'll say this, it's not just for Qatar, we committed with the WHO and various organizations not to just purchase the vaccine for the state of Qatar. We made sure we purchased and contributed to purchasing vaccines to go to countries who did not have the ability. And we made sure the vaccines we took for such countries are easily stored and in accordance to their resources. So basically, the commitment from the high political level was not just for the state of Qatar, across the world. We made sure we had so many different vaccination sites. We had primary healthcare. We had some semi-governmental institutions. We even had drive-through. We even had mass vaccination sites. And it's actually not above 20,000 per day. We reached up to more than 30,000 per day ability to vaccinate. We made sure we monitor any adverse events, and we were transparent with communicating to the community any adverse events. Next, please. The third success story is our flu vaccine. It wasn't a mandate, but more of a nudge, where we made sure that people, and we're working more and more to nudge people to take the vaccine. And what we had done to increase the uptake is accessibility again. So first, years back, it was only the government facilities that was given the vaccine. Then slowly the semi-government. But eventually, about 4 or 5 years ago, we added the private sector, where the vaccines was given to them, but it was given for free to all who go there. So whether you went to private sector, government sector, you got your vaccine for free. And we made sure that it's accessible all across. We even went to hotels, to companies, to vaccinate their staff, to make sure that they get their vaccine. And based on these actions, we noticed an increase in the uptake of the flu vaccine. Next. This is my last story, is that how do we introduce new vaccines? Basically, we took a method that ensures that once we introduce a new vaccine, we start correctly, we target the right people, we choose the right vaccine, we advocate it in the right way, and then implement. So what we do is before deciding on introduction of any vaccine in the state of Qatar, a new vaccine, and I'll use the example of the HPV vaccine, which was recently, a few months ago, introduced, is what we did is we first checked the disease burden, the efficacy and the safety of the vaccine. Is it affordable? Is it cost effective? Is it feasible? Can we sustain such a program? And then all of this information was escalated to the NITAC committee, where they discussed all of this and then came up with the recommendations. Once we have the recommendations, and it was evidence-based informed decision, and we decided on the target population, how we will deliver the vaccine. We gave technical guidance to all those involved, educated the medical professionals. We had workshops to educate them about the vaccine, answered their question, and we made sure even to train the vaccinators themselves to ensure that the way the vaccines are administered and handled is correct and safe. We monitor the implementation, the safety, monitor any adverse events. We also monitor social media for the comments, questions that the public will have. And again, you'll see advocacy and communications. And I think that's it from me today. Thank you.
Thank you, Dr. Suha. And let me just start by saying congratulations on your new position, and also congratulations to Qatar on their success stories. That was very impressive, and I'm sure that the experience that you shared is beneficial for our colleagues attending from different countries. So it's really impressive and really interesting how Qatar is focusing on equity and considering different circumstances of different populations in the delivery of vaccines, and especially to those who are unable to leave the house to clinics and receive vaccines at their home. And this is actually something that is very impressive, given the different circumstances that people are facing. And also it's really interesting to see that the population in Yemen have actually very high confidence in the vaccines, and the levels of hesitancy, as we saw from your presentation, is considerably low compared to other populations, and this is a very interesting. So just let me remind everybody to use the Q&A box for their questions. I have seen many requests for sharing the presentations, and the webinar is recorded and it will be disseminated widely across different channels. So the link, I think, will be disseminated to the audience. Next, we will move to the final presentation by Dr. Kira Sugarman. Dr. Kira is the acting lead of the Immunization Delivery Science Team in the Global Immunization Division at the U.S. Centers of Disease Control and Prevention. She is an epidemiologist with 20 years of experience in global public health. She was based in Addis Ababa, Ethiopia for 4 years at the CDC Ethiopia Country Office as the Immunization Program Director for GID, where she worked on strengthening immunization systems in childhood and beyond. Her work focuses on increasing immunization coverage, equity, immunization recovery, strengthening the life course approach to immunizations, operational and implementation research to inform improvements in immunization service delivery, and translation of evidence-based strategies into practice. She has published over 70 reviewed scientific articles, and she received her PhD from the University College of Cork, Ireland, and implemented the Epidemic Intelligence Service Officer Fellowship in Applied Field Epidemiology at the CDC. Dr. Kira, the floor is yours.
Thank you very much indeed, and thank you to MFNET for the invitation to participate in this very interesting and informative session. Thank you. Let me try share the screen and hope this works. Let's see this one. Okay, can you confirm you can see in slide view presentation mode, please? Are
yes.
you okay, great. Thank you very much. Okay, let me proceed. Thank you again for the invitation. I'm Kira, and it's a pleasure to be here today. And good evening, good afternoon, and good morning to everyone who's joined. I will just be expanding a bit on some of the topics that Dr. Osama mentioned at the top of the seminar, and I'll be specifically doing a bit of a deep dive into integration part of the life course to vaccination and some of the challenges, considerations, and best practices. Thank you. So we'll kind of go through what we mean by integration, and Dr. Osama touched on that, and then we'll do some information on how to integrate immunization services across the life course, and then challenges, considerations, and best practices and integration across the life course. And then there are many resources which I'll go in detail on as well. So what do we mean by integration? We hear the term a lot as it pertains to the immunization program. And there are very different meanings depending on the way it's approached in various different ways. So to give some examples of integration, there's integrated service delivery, and this is what we typically hear talk about is integration at the service delivery level, where multiple services can be co-delivered at the same time, or multiple services can be co-located with referral systems. So that would be, co-location, co-delivery of immunization plus other health services, or co-located that they can actually receive a referral for immunization or a referral for some other health service. So in addition to service delivery, there's also to bear in mind that integration can happen at the different system elements phases too. It can happen in data systems can be integrated. I think we just heard a little bit there from Qatar on that. We can have integrated supervision, integrated supportive supervision, for example. We can have integration at the supply chain management angle. And in terms of planning and budgeting also, there can be integrated services there for health. So it is a continuum. Integration is seen as a continuum, and often it's not to think of it as fully integrated necessarily, but there can be a scale and a range of the level of integration. It can be from fully integrated to partially integrated, but I think we're always trying to integrate services is the point. And so just to show here, this chart is showing coverage for different immunization and services across the health programming. And so you can see here that in the blue here is some of the immunization DTP3 and other the first dose of measles and other immunizations. And you can see this is coverage of those integrated services across different groups. And so basically this chart is saying that for immunization coverage is quite high typically, and so it is advantageous for other programs sort of to think about integration with the immunization program because of that high coverage we typically see for service delivery for immunizations. And so for the immunization program there can be advantages also in terms of maybe more economically. It could be advantageous to link up with other services as well, or also to reduce missed opportunities for vaccination. So just to go through some of the rationale for integrating immunization services, it can enable multiple contact points for immunizations, and you can also have other interventions at the same time for that target population example given here, and there are many. Vitamin A supplementation and deworming can also, happen at similar time points from the immunizations. The relatively high childhood immunization coverage rates, that's considered a strong platform. The chart we just saw, you can see that immunization, reaches high coverage often, and so it's a strong platform to link to, particularly for children under 2 years of age. It can also, as we said a little bit earlier, you can also provide an additional contact point for referral for services, for other services. And the example given here is if you're doing immunizations, you can also refer for family planning or HIV testing or other health services. It can also facilitate delivery across the life course. So for example, antenatal care for maternal immunization, you can do school health for adolescents. There are many different touch points across the life course that can be intersected with. It also supports the comprehensive approach for disease control The example here is you can have HPV vaccination and plus screening and treatment. And there's a growing need for these multi-sectoral approaches, in particular for integration. And one example, a key example, is for cholera control, where cholera vaccination is often done in tandem with water sanitation and hygiene interventions in an integrated fashion. Also, school-based delivery immunization as well, in that multi-sectoral approach with the departments of education typically. So there are many different examples. Just to refresh again and say that integration can really happen across many of the building blocks of the health system. This is the WHO building blocks for a health system. Really, we can view integration at any of these levels, sort of within the leadership and governance, within the health system financing. A key example is in demand and community engagement, where integration across the health system is advantageous. We just spoke a little bit about service delivery and service delivery for immunizations. Again, there can be integration at the health workforce level. And a key one is also in the health information systems, where you can have integrated systems there. And I think we saw in COVID a lot of integration there in the health information systems, where it was, we're tracking COVID, we're also vaccinations, and also adverse events following immunization and other health information system components that was advantageous to integrate. And just this is the slide that Dr. Osama showed earlier, and again, just to refresh, it's there are as was mentioned, all these different points across the life course, where there are touch points for potential integration with various different services down here on the bottom part of the slide, where you can integrate with reproductive and maternal health, neglected tropical diseases, malaria, hearing and screening, HIV, nutrition, water sanitation, hygiene, health education, and many other things also across different points across the life course. So it really is, this is a really advantageous. In addition to our routine system, you can also think of integration as it pertains to campaigns. So this document is a guidance document from WHO, which is coming soon, which will lay out the considerations for planning integrated campaigns for immunization and beyond. So the integration with immunization. It determines the feasibility of integrating the different interventions with campaign components and the considerations for planning those integrated campaigns, because it can be complex to integrate with campaigns, but also you can reach many folks, and also you can also additionally reach those zero-dose children as well. This is to give an example, and sort of a concrete example of integration with other health services. And this is a nice example from Cambodia, where they integrated early non-communicable disease screening and counseling along with COVID-19 vaccination. So we do have a lot of examples from integration in sort of the recent years in terms of how integration was planned and implemented for the COVID-19 vaccination. So this one's from Cambodia. This was work for that was supported by CHAI, where they supported a pilot in 10 large vaccination sites. They provided training, equipment, and supplies for health workers for this for the non-communicable disease screening and counselling during their COVID-19 campaigns. They ended up having nearly over 3,500 adults aged 40 and above received COVID-19 vaccination and were screened also for non-communicable diseases. And they were also referred to the nearby facilities for confirmation and diagnosis. Then this is an example from Nigeria. I see we had some colleagues from Nigeria on the line. This is again an example from COVID-19 vaccination integration in Nigeria. And it's an example of campaign integration, specifically as against the routine system. But in Nigeria, they leveraged COVID-19 mass vaccination campaigns to integrate routine immunizations and primary healthcare services in 3 different states. Using this method of integration, they reached over 500,000 children with routine immunization vaccines, and many of those were children who were either unvaccinated or under-vaccinated at that time. So they used the campaign to identify those children. In addition, for other health service programming, they did malaria testing and treatment, and also blood pressure screening as part of that initiative. In addition, in Nigeria, they've integrated COVID-19 vaccination into measles and polio campaigns as well. And they have supported adverse events following immunization, surveillance strengthening, and national dashboards as part of integrated services as well. Just want to very quickly give a quick overview of some other examples. Again, these are mainly taken from COVID-19 vaccine integration efforts, but you can think of these more broadly also. In terms of at this vaccine service delivery level, an example from Côte d'Ivoire was where they integrated school and community-based vaccination efforts for HPV and COVID-19 vaccine for young girls, and this was in campaign. In Lesotho, they integrated COVID-19 vaccination with TB services and other immunization services for measles and HPV. In addition, in Malawi, they built capacity for antiretroviral therapy, outpatient and non-communicable disease and antenatal care, and outreach for the clinical staff to administer COVID-19 vaccine in addition to those other services. In Armenia, there's an example where vaccination teams for hard-to-reach populations and mobile sites for COVID-19 also integrated seasonal influenza vaccinations. And I think a very, very important topic is vaccine confidence and demand. And I think I see some comments in the chats where, you know, it is definitely a large issue, and maybe this is where integration of efforts can also be advantageous around vaccine confidence and demand. An example here from Barbados, where they used integrated efforts for vaccination weeks for routine immunization, which they typically do, and they integrated that with COVID-19 and influenza immunizations. So just to very quickly touch on the benefits and risks, there are some benefits and risks to integration. The benefits being you can increase coverage for the new intervention to the level of this existing intervention, for example, immunization having high coverage, and you could potentially attain that. It can improve system efficiency. It can improve user satisfaction to the clients or the persons receiving the services with them receiving multiple health interventions at the time. It can increase demand, which is always good, and reduce missed opportunities for vaccination. And you can leverage funding opportunities for available resources for the various different health interventions. But there are risks, and so you can potentially, depending on the context, negatively impact the overall coverage, and that needs to be closely monitored. It could reduce quality of care if there's too many things to be done at the same time, and this can have an impact when there's many different services to be provided at one time. It can negatively affect the service experience if there's extended wait times, or if there's inefficient client flow or other things. Staff may not accept it, and it's additional responsibility, and there's additional training and knowledge that needs to go with that. And clients may not, or persons may not accept that, the integrated services, especially if one of the components has some level of stigmatization or other concerns that may be from one of the elements of the integrated services. So there are key considerations related to integrating services, and specifically with related to the interventions. You need to recognize that they need to have a similar target group as the routine vaccinations or in the campaign. They need to require similar timing as the frequency of vaccinations, and I think we showed that in some of the charts earlier. They have to have similar logistical requirements for delivery. They have to have acceptability also with respect to the persons receiving the intervention, the communities, and also the healthcare workers as well. And it does need to entail a similar level of skill among healthcare workers. So there are some points to consider with integrated services. and also other considerations related to the health system context, there does need to be high-level political engagement and will to do integrated services. It does take a very coordinated effort. Also, the national policies need to support this also in terms of the interventions. That there needs to be financial support for those commodities and for the logistics for these different integrated services. The structures need to exist to deliver these interventions. The responsibility for monitoring each of the interventions should be clearly defined because it may differ from the different interventions. And then the health workers need to have the ability to cross and cover both of those interventions. And to ensure that there's not a burden, an additional burden placed on service delivery. Just to wrap up a little bit, I did want to identify this nice document, which is from the WHO on integrated services across the life course, the guidance document. And it really is a nice document where you can look at an integration checklist and see the guidance and the considerations when linking to specific interventions you might have in mind. It gives examples of strategies to integrate services and opportunities for integration, and nicely outlines also some of the pitfalls that do exist with integration. So that's a nice one to review. And then there's also a similar document for COVID-19 vaccine integration, which is slightly different. And this guidance document from WHO UNICEF that outlines the various different considerations also for integration for COVID-19 vaccine, gives some examples, and overall goes through the global principles for the framework for COVID-19 vaccine integration. There are a set of, there's a guidance document here on the picture. There's also a set of frequently asked questions and a series of presentations as well. You can find those on the link. And then I just wanted to finish with this nice list of resources available from WHO, UNICEF, and others on all these integration efforts. There's links here in the presentations, and you can review these at as your time permits. And thank you very much for the opportunity. Thank you.
Thank you, Dr. Kira, for this very informative presentation and for explaining integration from various aspects and things to consider in applying integration of life course immunization interventions with other interventions. And also thank you for recommending a number of I'm sure, very beneficial resources. And I encourage everybody to go through these resources once they have time. And thank you so much for your time and for being here. We have a number of questions, so maybe we can go through some of these questions as the time allows. So maybe the first question is related to vaccine hesitancy. So we have a question that says the life course immunization is an ambitious strategy, as we can see in countries that still fight the anti-vaccination movements, even for the vaccines, childhood vaccination for under 1. So what is your advice on how we can move to reach such ambitious goal? And what is the role that we could do that could be done by WHO to support in this battle? Dr. Osama, maybe since it's related to WHO, maybe you can.
Thank you, Ms. Lynn, and thank you. I see this is from Dr. Abdulwahid Al-Sururi, and thank you very much for this question. It's very important, and greeting to you. Long time we haven't met, Dr. Abdulwahid, but he's talking about Yemen situation, and I know very well the situation over there, and we have to start to say that it's some political issues is playing a role in this. But apart from this, we have to think all the time how to influence the policymakers in taking the decision, how to influence even the community, even to demand the vaccine and the vaccination. If we think about the influencer, I can take some examples, like the NI tag should be one of our main tools to convince those policymakers about the vaccination in general, for under 1, and of course for under 2, or even for the life course. And the most important thing that the NI tag they can play here, I think, is to show the benefit of the vaccination from the local data, from the local history, and even from the region, and even from the globe. I think in this case, if we put some concrete data, they can't like deny the importance of the vaccination. This is very important. And I think again, the academia, they need to play a very good role again in collecting this data and presenting this data in very convinced way. And then we need to use the influencer for the community influencer, for the or community leaders at the nationwide, who can talk to the politician, who can talk to the policymakers, who can talk to the Minister of Health, who can talk to the Minister of Finance sometimes if we need any fund to be there. Another third point, what I can say, which is very important, we need to show that our services is not only confined to the immunization. Because in my presentation, I mentioned in many countries, we are giving the polio vaccine, only the polio vaccine. Then the people, they will very much like bored and arrogant to say that you are giving us only 2 drops while we need food, while we need some other treatment. So what are you doing? So I think, again, coming back to the integration, whenever we can, we will be able to support the integrated health services. And I know that even the authorities in the North Yemen, they were asking for such like integrated and comprehensive primary healthcare services, which is good, of course. To do it through the health facility or to do it through the outreach activities, this is another issue, another area for the discussion. Now, what we can do as WHO, in fact, we are working on this issue because we know the situation very well, and we are the most important thing that all the partners, especially WHO, UNICEF, and Gavi, they are talking the same language, to be on the same page, with one voice to talk with the government. And we have colleagues, they've been in a mission from Gavi and UNICEF, and ourselves, like from EMRO, we will be in a mission to Sana'a to talk to the policymakers on the health, and to talk even to the Minister of Health to see how we can improve, because we know now what they want. They want to have all the health facility functional. They need to expand all the outposts. They don't want to have these outreach activities. So I think we need to, sometimes one of the issues, you need to go with what the government, of course, this is very right to ask for this, but maybe we need to have it on phased manner. We can't make at the same time with this situation, all the facilities working without doing the outreach activities. I hope that I try to summarize what I can reply to Dr. Abdulwahid. Over to you, Christine.
Thank you, Dr. Osama. Moving on to the next question, we have a question from Morocco, and specifically to the victims of the earthquake and the floods. Of course, our prayers go to the victims and their families. But what are the vaccines that are indicated for those victims in such situations?
If you want, I can continue responding to this. In fact, yes, it is very important. Always in the emergency, let me talk about the regular, even normal, like vaccine to be given during this emergency. We are talking about the measles and rubella, because we expect in such situation, even the outbreaks, it can happen. The polio vaccine, it is very important just as a preventive things. But nowadays, even for the earthquake and even for what's happening, the flood in Libya, I think it's very important even to boost the immunity with regard to the diphtheria and pertussis. So diphtheria and tetanus, diphtheria and tetanus, especially now for tetanus, for the wounds. It can be as a preventive and even as a management for the wounds now, which will happening from this disaster. And this is what we can do, but I think it should be done as quick as possible before the outbreaks can happen and can spread out. And of course, we are talking about cholera vaccine, but cholera vaccine, to have it as preventive, like all of the sudden, if we have this, we need to use the cholera vaccine. I think it is not very much, it is not recommended, but it should be kept in mind that anything it happens, because now we can expect such thing will happen with such situation of the hygiene at the sewage, or even using the safe water. They don't have access to the safe water now, even the safe food. So I think it is very important to keep it in mind. Over.
Thank you, Dr. Osama. So we have a couple of questions directed to Qatar. So the first question, Dr. Suha, was related to the HPV vaccine. So could you please explain the rationale behind introducing this HPV vaccine? Was it because cervical cancer is prevalent in Qatar?
Okay, thank you for that question. And no, we do not have high prevalence of cervical cancer in the state of Qatar. But what we noted is that there was an increase in genital warts and pre-cancerous or changes once women went for a cervical smear. And we discussed all the data, we discussed all the possibilities. We knew we were not having such high prevalence of the disease. And we looked at even the cost of the vaccine itself. And a joint decision supported by higher authority was made that saving one woman from the agony of cervical cancer was worth the cost and all the measures that we get to implement. And we try to always meet the global vision and the global targets. So we are part of hopefully being part of the global vision for WHO and target for 2030 to have most women vaccinated with HPV and to have more screening and to decrease. So we didn't want to wait until we have an increase in prevalence. We've decided to be proactive and hopefully not reach that level. I hope I've answered that question.
Yes, definitely, Dr. Suha. So the other question for Qatar was, do you have vaccination error in Qatar? And if yes, at what percentage? And do you have reporting system, and how do you minimize it and keep it under control? Too many questions, but...
No, that's okay. That's okay. I'll try to address them all. So I presume what they meant is that an error in giving the wrong vaccine or the wrong age group, and etc. Let me put it to you this way. I've been in charge of the vaccination in the Ministry of Health until my recent change in post for about 7 years. And I was trying to remember how many cases got reported. And I would have to say, I can't think of more than not even 5 or 10 cases in these 7 years. Okay. And maybe just the one that came to mind was one. And we understood where the error happened, which could happen anywhere. The thing is, yes, we have a very strong monitoring system. Any facility, even the government, if they want to provide vaccines, they have to comply with our policies. One is that anybody dealing with the vaccination should be trained on proper vaccine management. They should show us the certificate. They have to be licensed. We go on regular visits to all sites that provide vaccination, supervisory visits, check their records, check everything. So errors are part of that. By mandate, if they want to maintain their license, they have to report to us. So that means reporting the number of vaccines, type of vaccines, any errors, any wastage, any side effects. And if not, they face penalties. We go very extreme and very strong when we put in our policies and guidelines to these facilities. And so far, they were all compliant. And if any center is not compliant, we reach a stage where we suspended some of them for a temporary period of time until they rectified whatever the error was. And we even ended up by withdrawing the license of 1 or 2 facilities who did not comply. And guess what happens? These messages are very strong. So that makes all others fall into place and make sure that they follow our policies. We have a very strong adverse event reporting system. In the past, it used to be by email or forms. There are still some people who use it, but now with our system, it's also automated, and it is again mandatory. So even government facilities have to report, and it's immediately investigated and action taken to prevent it from happening again if it was a human, like the way the vaccine was administered or stored. But if it was just a simple reaction to a vaccine, then we just simply advocate and raise awareness. Thank you. I hope I addressed all the questions in that one. Thank you.
Yes, I think you did. Thank you, Dr. Suha. So I will move on to a question related to integration. So Dr. Kira, there's a question. There are people who are still afraid of vaccination. So to what extent does this affect integration of the vaccines with other services? So I think what they mean is that, does it affect the demand to seek other interventions? Over.
Yeah, thank you for the question. I think it's a very important question, and I think it's like it's an example of there's considerations to bear in mind when you think about integrating with our other health programs. And so, of course, we don't want to affect demand for immunizations. In fact, we want to bolster the confidence in the vaccine for sure in all instances. So I think you just need to think about that. If there's known concerns, then you would really need to think about that as what services you're going to integrate. There are many different examples where it's not gone the best way, and so I think we want to avoid that. I think, you know, understanding the population and the concerns, I think, you know, some of the discussion earlier from the country experiences was showing around, you know, the sort of understanding the misinformation and disinformation environment and sort of the social listening and understanding what's going on in the population and the concerns before you sort of delve into that integrated services would be good, especially if you have any signals that there are concerns on a specific topic or specific approach or vaccine or other health service. Then I think you'd really want to carefully look at that and sort of look at that approach and probably sort of do a bit more formative and qualitative guidance on that, as to say if it really is going to be useful to your programming long term or not, or is going to you don't affect your programming. So I think that the point was, yes, immunization coverage is high relative to other health services in many instances, but we don't want to reduce that at cost to other things. So I think it has to be a balance to do that, and others might want to weigh in as well. Thanks, from their experiences. Thanks.
Thank you, Dr. Kira. So moving on to another question. So if possible, could you explain if the NITAG is involved in the process of API vaccination surveillance? So anyone can just intervene and provide an answer.
If I may, for us in Qatar, yes, NITAG is very strongly involved. So basically, as I mentioned maybe very quickly during the presentation, for us to do a schedule, change the schedule, update a schedule, introduce a new vaccine, change the type of vaccine, even the seasonal influenza vaccine, which is an annual campaign, NITAG starts the discussion. And what they do is they look at scientific evidence, they look at data, they look at utilization in the country, they look at the number of cases. So they look at every piece of information possible, and then they vote and they come up with a joint decision, which comes to us in the ministry. It goes up to the higher authority. So NITAG plays a very strong role in our vaccination, be it the national immunization program or the optional vaccines. Even when, for example, with the HPV introduction, it was a decision it was a matter that was discussed in NITAG and agreed on and then escalated to higher authority. NITAG also was where we decided that we will do a gender neutral vaccination. So we were not just targeting women, we targeted men and women with our HPV vaccine, even the age groups, all of that. So NITAG plays a very, very strong role when it comes to vaccination. And if you allow me, Lina, for a second, there was a question that was addressed by Dr. Muhammad earlier, the very first question when it comes to vaccine hesitancy. I think there is no country in the world that's not facing an increase in vaccine hesitancy. Can we stop it? No. Can we try to decrease it? I think yes. And one of the things that's been done here in Qatar is that transparency, communication. We're proactive. We don't wait until it escalates, until it becomes a huge rumor. The minute we get, you know, any hint of it's becoming a problem, we try to immediately respond indirectly. We are transparent in our data. So be it COVID, be it flu, be it any other illness, we actually publish number of cases, number of hospital admissions, number of deaths, number of whatever complications, as much as we can. I think that's very important. During COVID, I remember, if I may share this one sentence, Her Excellency told us in a meeting that they were ministers of health meeting, a global one. And actually one of the European countries' minister told her, you must be crazy. You're too transparent. You share everything. And we were laughing about it. It's not that we're crazy, but we believe if you want the confidence and trust of your people, just be transparent. Even with the changes in COVID, where we all didn't know everything. So we had some information, then that information changed. So actions and decisions were changed. We were transparent. We said, we don't have all the information. As science evolves, as more scientific data comes to us, we will come out and talk to you. And that's to the community. That's the best thing. And I think one of the things Dr. Osama pointed out is you need to use your social influencers, whether we like it or not. They exist. They have more power than us, the scientific and the technical people. So there are very good people that talk very wisely, that are respected by the community, and you need to use them. There are so many things that we can do. And I think if the countries work together, we'll have even a better outcome. Thank you.
Thank you, Dr. Suha. Dr. Osama, please.
Yeah, quickly, because I just to complement on the issue of NITAG, and because I know that there are many other questions. It is good that this is very much interactive. The surveillance. I think we were talking about that NITAG is the advisor body for the Minister of Health. Because of that, they need, whenever we did new vaccine, I'm taking only part of this, the new vaccine, and monitoring even the impact of the vaccine when it's introduced. That means you need the surveillance data. So it is very important, and I tag to look at the data generated from the surveillance. And we talked that all the time, that even the NITAG, whenever they take any recommendation to be sent to the higher authority, it should be evidence-based. Evidence-based, that means data, that means surveillance, in addition to many other tasks they can do it. Thank you.
Thank you, Dr. Osama and Dr. Suha, for your answers. We have still so many questions, so I'll try to just choose the most important ones. So we have a question: how can we reach the marginalized populations? I think it's Dr. Suha, you highlighted the issues related to equity and to reaching not only the nationals, but also everybody living in Qatar. And I think that's relevant to your presentation. And I also think Dr. Osama, this is also pointed out in the immunization agenda. So please provide answers if you would like.
Yeah, thank you very much for this question. This is very important, and in fact, we experienced this even during the COVID, during all the vaccination, all the time the marginalized people, and they are like locating in the slum area, in the remote area. So how they have a problem of the access, geographical access, and then cultural access, and maybe awareness access. So we need to work on all of these areas then to reach to and to have access to. In fact, what we need to do is to make this the vaccine is easy access to them. That means it's the most convenient to them from in the place, in the timing, because sometimes even for those marginalized people, they don't accept to be vaccinated unless the men or the husband they are there, or at least they can get their consent. So we need to think about this, to go to their places in the right time, in the right place, and of course generating the demand among those marginalized people. It's very much relying on the influencer, on the community leaders from their local community, and here I'm referring especially for the religious leaders, and of course if there is any authority, it's very important to reach to them. So I think This is the main issue in this case. And by the way, those marginalized people, sometimes we think that they don't accept the vaccine, but whenever you get the vaccine, very much vaccination process, very much convenient to them, they are very thirsty to take any health services and they will accept it happily. Thank you.
Dr. Suha, please.
Yeah, well, I think I spoke a little bit about that when I said that when it comes to accessibility from a geographical point of view, that we have more than 30 health centers, government health centers, and they are all across the state of Qatar. So whether you live in any area in Qatar, you'll have a close by health center. But also on top of that, there are policies, there are laws that support us. Number one, it's free of charge. Vaccines in the state of Qatar are free of charge. So whether you're rich or poor, you're a local or you're a resident, you have access without it costing you any amount of money. We took it a step further because most of our expat community are single male workers. So what we did is they kind of have their community and they live more closely to each other. We set up health centers, hospitals near them, so they can even walk there. They can. It's not that far from them. So that made it easier. We made sure that the people who work in these places are multilingual because sometimes the level of education and language barriers were there. We went to these camps. We had education and community engagement teams that went to these people's accommodation to explain the importance of vaccines, that it's free of charge, that there's no penalties, etc. I'll give you two examples. So that we did it even during COVID. And plus, we went to the extreme that when we did campaign, the last measles MMR vaccination campaign, we made it clear to all facilities, even it was for children, that we told them if a parent had a child who was not legally in the country, so let's say they came by a visitor's visa and never left, accept them. Don't ask for a residency permit. Don't ask them where are your records. If they have any ID, just register them and vaccinate them. We did not want to miss vaccinating anybody. Like Dr. Osama said, we involved religious leaders. People in Friday prayers spoke about the importance of vaccine. So we tried our best, and maybe there are still a few here or there, but I think free of charge, various locations, making it easy for people to get, then that way you can reach everybody. Thank you.
Thank you so much for your answers. I think we only have 3 minutes left, so we'll have one more question. And for the COVID-19 vaccine, since it was introduced as an emergency vaccine, so we are aware that a lot of people had issues with the vaccination even before the pandemic. So do you think that there's a strategy that we could implement as an alternate to the one that was implemented during the pandemic?
I'm not clear on the question. I'm sorry. So are they asking about to
Can you repeat the last part of the question?
So do you think we need a different strategy to overcome the vaccine trust? So I think the way the COVID-19 vaccine was introduced in some, let's say like in some context was not, did not actually address this issue. So do you think that there might have been another strategy, or do you recommend other strategies for future emergencies?
If I may say something quickly again, because I think it is a big topic, in fact, and we can talk like for half an hour. But quickly, and this is the most important thing that for us, that what we identify, that we need to again, any decision, any intervention, any approach, it should be evidence-based. And now because of that, even like approaching the communities, approaching the community leaders, we need to have on evidence-based. Because of that, now we are trying to start an initiative on behavioral and social drivers. What can we get even for routine immunization, for COVID, for synchronization, integration, whatever, all of this, what's the social drive behind this? And this can differ from one community to another, from one village to another, from one area to another. Because of that, now we are working on some priority countries now, especially in Pakistan, Afghanistan, Somalia, where we have most of the zero-dose children in our region, and even included in the 20 priority countries in the world, which have a big load of zero-dose. This quickly, but otherwise we can explain much more. Thank you.
All right, so thank you so much. I think time is up. I know that the topic is very, very interesting, and I'm sure that a lot of people in the audience would sit here and listen to this discussion for hours. However, thank you so much for the very informative and productive discussion. And thank you also to the audience for the proactivity and the questions. And hopefully we see you again in the next webinar. Thank you so much for your attendance, and thank you to the speakers.
Thank you very much, Ms. Lynn. Thank you for infinite. Thanks for all participants and my colleagues presenters. Thank you.
Thank you very much.
You.
Thank you.
Thank you. Thank you very much. مع السلامة and bye-bye.
Assalamu.